Welcome to The Explainer. Today, we're unraveling a medical mystery that affects countless people, but honestly, it rarely gets the spotlight it actually deserves. Just imagine this for a second. You're dealing with chronic dizziness, maybe room-spinning vertigo, or a really sudden decline in your hearing. So naturally, you go to the doctor. You probably even bounce between several specialists, hoping for some answers. But instead, you're shuttled from office to office, you go through this massive battery of tests, only to be told that structurally, everything looks totally fine. Or they say your symptoms don't quite fit their criteria. Basically, you're told there is nothing wrong with you. So why does this happen? Why are so many dizzying and hearing-impaired patients just falling right through the cracks? Okay, let's dive into this. To really understand the problem, we have to look at how modern medicine is actually structured. Clinical practice today is incredibly siloed. We've got these neat, distinct, non-overlapping categories, right? Neurology over here, otolaryngology over there, psychiatry, cardiology, they all have their own boxes. But as this quote captures so perfectly, the human nervous system does not operate within these artificial boundaries. When a complex patient walks in with symptoms that blur those rigid lines, our diagnostic infrastructure literally just breaks down. And that breakdown, that creates what we call the diagnostic void. It's this sort of medical no man's land where patients find themselves completely trapped. When conditions overlap, folks complaining of spatial disorientation or chronic dizziness or weird hearing deficits, they're left undiagnosed or misdiagnosed for years. They're caught in this massive systemic mismatch between how we classify diseases in a textbook and the actual messy physiological reality of how the brain and the inner ear interact with each other. Now, what's really interesting about this slide is how we can see this play out with two incredibly common conditions that constantly overlap. On the left, we've got vestibular migraine. Clinical guidelines define this as an episodic central disorder, meaning attacks last minutes to days, and you usually get that classic light and sound sensitivity. Now, on the right, we have PPPD, or persistent postural perceptual dizziness. That's classified as a chronic functional disorder, causing persistent dizziness on most days, usually after some initial triggering event. Guidelines try so hard to separate them, but neurologically, they actually share interconnected brain circuits. They both involve sensory processing, they both utilize serotonin and dopamine. When those systems dysregulate, the brain's threat assessment networks can actually transform a temporary episode, like a migraine, into a permanent, chronic condition like PPPD. The categories are kept totally separate, but the brain pathways, deeply shared. Which brings us to a really crucial concept to help explain why these symptoms flare up in the first place: the threshold model. Listen, a lot of patients get incredibly frustrated when their very physical dizziness is dismissed by a doctor as just anxiety or stress. But here's the thing, stress doesn't cause these disorders. Instead, think of your nervous system as a cup, and that cup has a certain tolerance for sensory input. Things like poor sleep, genetics, a recent illness, or hormonal fluctuations like perimenopause, those factors start filling the cup. Stress is simply the final pour that makes the cup overflow. It pushes an already lowered nervous system way past its limit and triggers the symptoms. So it's an amplifier for sure, but definitely not the root cause. And hey, this isn't just theoretical textbook stuff. The Vestibular Disorders Association, or VEDA, recently held this virtual conference called Life Rebalanced Live. They brought neurologists and patients together to hash out this exact issue. Hearing real patient experiences firsthand reinforces a really powerful truth for us. In the real world, symptoms almost never fit neatly into one single box. People are out there living with the complex, messy reality of overlapping conditions every single day. Moving on to Section 1, the imitation game, structural and pathological mimics. So sometimes certain structural anomalies in the ear or brain can perfectly mimic entirely different diseases, which creates a literal diagnostic trap for the clinician. Let's pit two of these imitators against each other. Picture a 35-year-old woman presenting with progressive asymmetrical conductive hearing loss. The classic textbook diagnosis, otosclerosis, which they often treat with a middle ear surgery called a steepodotomy. But wait, plot twist. This exact presentation is perfectly mimicked by SSCD, or superior semicircular canal dehiscence. SSCD is a structural issue where a tiny piece of bone is actually missing, creating a third window in the inner ear. If a well-meaning surgeon misdiagnoses SSCD as otosclerosis and goes ahead with that staped surgery, it is highly, highly dangerous and can cause permanent, severe sensory neural hearing loss. So the crucial point is, to avoid this trap, clinicians absolutely must implement strict rules to catch these mimics. For that autosclerosis dilemma we just talked about, the absolute imperative preoperative rule is utilizing high-resolution cone beam CT imaging. This specific kind of scan exposes the patient to way lower radiation than a conventional CT, but allows the surgeon to definitively see the bone structure. They can completely rule out SSCD before they ever even think about attempting middle ear surgery. It is literally a lifesaver for the patient's hearing. And the list of these sneaky imitators just goes on. Look at how our siloed medical system is failing these patients. Take trigeminal neuralgia. It causes severe shock-like facial pain. But because dentists and neurologists operate in totally different worlds, patients sometimes undergo completely unnecessary dental extractions, literally pulling teeth, before they finally get a neuro referral. Or look at vertebral artery dissection, or VAD, which is a tear in the neck artery. The neck pain mimics a simple muscle strain, and the vertigo is just dismissed as benign. The clinical trap? Missing life-threatening brainstem emboli. Or Kagan syndrome. It's an autoimmune disease causing vertigo and hearing loss, but it's frequently misdiagnosed as simple infectious labyrinthitis, which seriously delays critical steroid therapies. Let's move to section 2, the real-world stakes, connecting the ear to the ground. We really need to look at the hidden, highly dangerous physical connection between hearing health and your risk of falling. Check out this staggering statistic from researchers at Johns Hopkins. They found that adults between the ages of 40 and 70 who had even mild hearing loss were 3 times more likely to experience a fall compared to people with normal hearing. 3 times! That's a huge jump, and it is definitely not a coincidence. And this brilliantly illustrates exactly why. You might think falling is just about your muscles or your joints acting up, but when you walk, your ears are picking up subtle cues, like the sound of your footsteps or crunching gravel, that help keep you steady. Hearing loss mutes that environmental awareness. But even more importantly, let's talk about the cognitive drain. When your hearing is impaired, your brain uses an immense amount of extra mental energy just trying to process sound. That added cognitive load literally drains the energy your brain desperately needs for balance and spatial awareness. It leads to major fatigue and a much, much higher likelihood of tripping.
But here is the incredibly hopeful data point. According to another long-term Johns Hopkins study, for those at the highest risk, treating that hearing loss with simple interventions like hearing aids can slow cognitive decline by a massive 48%. Treating the ear protects the brain, it slows cognitive fatigue, and it directly reduces that severe fall risk we just talked about. Win-win, right?
Which brings us to section 3, bridging the care gap, integrated solutions. So how do we actually fix this broken system? Well, the first step is fixing the bottleneck. And we do that using allied health triage. We just cannot rely solely on overbooked specialized doctors anymore. Audiologists and physical therapists need to be right there at the front line. And we absolutely know this works. Look at the data. In remote settings, audiologists triaging pediatric patients for ear conditions achieved a 91.7% diagnostic agreement with the specialists. They missed 0 cases of eardrum perforations. If we shift triage to audiologists and PTs, we can catch these complex overlapping symptoms early and route patients accurately the first time. Let's move to and see how this builds into a really structured care roadmap. Because treating overlapping conditions requires a multidisciplinary approach. Step 1 is absolutely crucial. You have to prioritize suppressing the episodic triggers first. If you have BPPV, loose crystals in the ear, or active migraine attacks, those repeated hits keep the brain's threat network in a state of high vigilance. Once you suppress those fires, the brain can finally calm down. From there, you utilize telehealth for home-based rehab, you implement gradual visual exposure therapy, and then you bring in dietary changes and highly specific medications. And ultimately, true, lasting recovery relies on these brain health fundamentals. We are talking about stabilizing the entire nervous system. Because these conditions overlap right there in the brain's sensory and threat networks, you have to build resilience through high sleep quality, anti-inflammatory nutrition like the Mediterranean diet, proper hydration, and exercise. Remember that threshold cup we talked about earlier? This is how you make that cup bigger so the system doesn't overflow so easily. Which leads us to this final provocative question. Are we ready to stop treating the ear like it's some isolated organ on an island and start treating the whole network? Because as long as we keep the inner ear, the brain, and the body in completely separate clinical silos, patients are going to continue to fall right into that diagnostic void. It is time for a major paradigm shift in neuroaudiology. Thank you so much for joining me for this explainer. I really hope this gives you a powerful new perspective on how our integrated bodies truly work.